Hello everyone, welcome to Glasgow Loves EU lockdown live stream. Tonight we're delighted to welcome Professor Faisal Ahmed, who holds the Samson Gemmell Chair of Child Health at Glasgow University Medical School. Thank you very much for coming along and agreeing to talk to us. My name is Fiona Wishlade, and also with us on the chat are Jenny Wilson and Bernd Poor. Jenny's checking social media for questions, so if you have any questions to ask Faisal, put them up on Facebook or Twitter, and we'll try and get to them. And Bernd's making sure that all the technology works for us and is recording the session for people who want to watch it later. So tonight we're really pleased also to be supporting Rare Diseases Day, which was yesterday, 28th of February, and we hope to be helping to raise awareness of rare diseases and their impact on people's lives, as well as shining a bit of a light on some of the impacts of Brexit that are less in the public eye than perhaps they should be. And on Glasgow Loves EU's Facebook and Twitter accounts, you'll see that we've linked to raredisease.org.uk, where you can find more information about their activities and also donate to them. So just by way of background, before we start, we got in touch with you having seen a letter that you and some colleagues had written to the Lancet, warning about the impact of no deal Brexit on the treatment and research of rare diseases. Perhaps before we get into that, you could give us maybe a little bit of background about your specialism, bearing in mind that most people watching this won't have a great deal of or be like me, won't have a lot of medical knowledge.
Right. Well, first of all, thanks so much for asking me to be here tonight. This is rare conditions or rare diseases is something which I've had an interest for a long time. And as professionally, I'm a medic. And within that, I work in a very niche field of pediatric endocrinology, which is all to do with looking after children where there are any concerns about their hormones. Now that itself, there's some common conditions, but a lot of the work which we do is looking after children with pretty rare conditions. And I've had an interest in rare conditions, specifically in the endocrine field, for over two to 3 decades now. And I've been in Glasgow now for about, just over 20 years now at the Children's Hospital. So I've been working in this particular area, and over time, I've also realized that whether you could work in endocrine fields or you can work in some other fields, there are people with rare conditions in all of these areas. And so I think from that point of view, that's my background really. And when you work in rare conditions, given the fact they're so rare, it's completely natural to build links with people, not just within your own circle in Glasgow or Scotland, but even further beyond. And that's where the links to Europe come from.
Okay, so I mean, you've mentioned that the conditions that you're concerned with aren't so common. So I read that sort of like 1 in 17 people will be diagnosed with a rare disease.
Yeah, that's right. So the official definition for rare disease, I prefer calling rare conditions, but it's the same thing: rare disease, rare conditions, is about somebody who's got a condition which is as common as 1 in 2,000, or as less common than 1 in 2,000 is a rare condition. Probably about 7% of the population is supposed to have a rare condition. Okay. But that's the whole thing about it. People say, well, actually, it's each individual condition is very rare, but when you take all the rare conditions, then they're not that rare, really.
Yes, that's a lot of people and families who are, and their families who are affected. Overall.
And most of these tend to happen in children. So a lot of these conditions are genetic in origin. So children, often the commonest time when somebody presents with a rare condition is usually after birth. And probably 75% of them will happen in children less than 5 years of age. So yeah, and that's why as a pediatrician, I'm a lot more involved in this particular area.
Right. Okay. Okay. So, I mean, I know you've been involved in several international initiatives in your field, and amongst these, you coordinate the European Reference Network for Rare Endocrine and Conditions. Now, trying to find some information about this on the web, you know, saw that there were 24 of these networks. Can you explain a little bit about what they are and how they work?
Yeah, sure. So a number of years ago, well, we've known about rare diseases, rare conditions for a long time, and how important they are, and how any one particular center may not have the expertise to deal with all of these conditions. So to an extent, Europe has been working for a while in the field of rare diseases, and they developed guidance for that. They developed a plan, a rare disease plan, some time ago, and then a number of countries within Europe have been adopting these plans and creating their own plans locally in their own countries. Some of the countries have been ahead of the game. So, for example, in France, this was happening a long time ago. But we can't downplay what we've been doing in Scotland either, because in Scotland, we've had something called managed clinical networks. You might have heard of this word. We've been working in this area for a long time, and we knew that if you the mantra which we've been using in Scotland was that the highest level of care as close to the patient as possible. Okay. Now, it doesn't necessarily mean that the care is available in that center where the patient is, but we try to deliver the highest level of care, and that might be through having a network of people. Okay, so the rare disease plans which we're developing in Europe also highlighted the fact that we should be thinking about working as networks. Okay, and the idea was very much that if you work as networks, then you can share knowledge, you can share data, you can share expertise, and deliver care as closely to the patient as possible without the patient having to travel. Okay, so even in Scotland, we have difficulty, people traveling from the north of Scotland to the central belt for some special expertise. So we have telemedicine, we have a number of different kinds of things. And the advantage over here, of course, is that most of us tend to speak one language, but whereas in Europe, that's a lot more difficult. And rather having a patient moving from the east to the west of Europe, or south to the north, or whatever, then the idea was that we should develop some kind of a virtual network where clinicians could be talking to each other and developing ideas of how to treat a patient in best practice, but also within this virtual network, share data and do all those things. So that's where the European reference networks came from, was these kinds of concepts of collaboration. And the three words which the networks are based on is share, care, and cure. Okay, so those are the three things they would really like to do for people with rare conditions.
Okay, so that's, I mean, you talked about people patients not having to travel. So the principle then is that you link to somebody else in another country through the clinician that you're dealing with in your own country.
Yes, okay. yes, that's right. So the idea very much is that these networks, the European reference networks, will be provided with some resources which will allow them to do all of these activities. So some of these activities are funding for developing registries, okay, so that that will allow people to collate data and share data, and which could be used to improve practice, but also research. And another platform which the European reference networks had or have is a clinical patient management system, which is it's actually a platform. It's a closed, secure platform where information about the patient can be entered, and then clinicians from all the different centers in the reference networks can join up, can meet, and then discuss the case, and then come up with a solution.
Okay, and I mean, can you give us an idea of the what kind of impact some of these networks have had? People always like to hear success stories, don't they?
Yeah, well, so I say that rare conditions and rare diseases are somewhere 1 in 2,000. Many of these conditions we would see, maybe once or twice in a period of 20 years. So, for instance, when we were in the ERN and Glasgow, where I work, was an endo-ERN and ERN bond, which is for rare bone conditions and rare endocrine conditions. We came across a child with a very, very rare condition, and I don't want to necessarily go into detail with the condition, but
Sure.
it was such a rare condition that I'd never seen a child with that condition in my 20 years of working in Glasgow. And we were thinking about starting this child on a new form of therapy, which is very, very expensive, and it would require, and we have to make a decision whether this child really needs it or not. And in those situations, it can be quite difficult. I mean, in that situation, I can't discuss this with anybody in Scotland because there's nobody else in Scotland with the same condition. And then there are maybe 1 or 2 people with that kind of severity in England. So the expertise doesn't exist in the UK to have that discussion. So I entered, after taking consent from the family, I entered the details of the family in that system, and then arranged a meeting with some other experts in different parts of Europe, and we came up with a solution quite, in a nice way, and decided that we'll go ahead with the therapy, and that was the right sort of decision because the child's doing really well now. For those particularly rare conditions, I think it's a nice model to use. And by having one can say, well, actually, I could have picked up a phone and had that discussion with another colleague in Paris or somewhere, and that still happens. But by doing it through that system, I also had a recorded letter which said, well, actually, look, this is what we discussed, this is how it happened, and that is also helpful from the point of view of governance and so on to say, well, actually, this is what we did. So yes, it provides that structured thing.
And that presumably also sort of like builds towards a resource that can be used in the future as well, having had that experience in that process.
Yes, because by doing it through that, by talking to experts, we also identified gaps in knowledge. And so what happens then is that those kinds of gaps then are developed into an education program where we would then move that to doing webinars or those kinds of things to say, well, actually, we should do this. So really from that particular condition, having learned myself from that, having engaged with the right clinicians, then we developed a webinar on that particular condition, and then had people from Scotland coming to that and also from other places. So you can see how the ball rolls when you have that kind of process.
And then you're able to sort of like disseminate that knowledge and expertise as well. Okay. Jenny, do you have some questions in from social media?
Yes, there's a couple of questions. They're sort of COVID related. The first one is somebody who has OI and another person in their family has that. I guess you know what that condition is. And they've been shielding. I think their consultant had said to shield since March 2020, but they don't seem to be on the priority vaccine list. So do you think they've been left off, or will it be upcoming?
So that's Sorry, should I address that one first?
Yeah, do you want to do that one first?
Yeah, okay. So that's a condition called osteogenesis imperfecta, which there's a wide range of people with this condition. So some of them are very, very mildly affected, and some a lot more seriously affected. And during the COVID epidemic or pandemic, there's been quite a lot of guidance for this. There's guidance on the Brittle Bone Society's website, and and that's actually based in Dundee for the UK. So people can get in touch with that. But generally speaking, people have felt that in some people with more severe forms of osteogenesis imperfecta, the chest can be affected, the shape of the chest can be affected. And if that's the case, then they may have difficulty breathing, generally speaking. And then those are the people who would really be considered for shielding. So if those kinds of problems exist, then that would be the criteria for that. So I would say the person who's made that query should get in touch with the Brittle Bone Society of UK, who are based in Dundee, and they can provide them with more advice on that.
Okay, and the other question was just, have you seen a reduction in the number of referrals to paediatric medicine, and maybe less people being diagnosed this year with the COVID?
So I get the impression, so this is not just about rare conditions, but this is probably about all kinds of referrals to pediatrics. I think it probably hasn't affected referrals from general practitioners and other doctors. But what has happened is that sometimes the time to be seen in the hospital has taken a bit longer. However, all those things are getting better because doctors like us are getting used to talking to other people, new parents or parents of new children, by telephone, by attend anywhere, video, sort of remote consultations, and all those things. So I think from that point of view, those kinds of things have picked up. What's taking longer are procedures. So if there's a person with a rare condition who needs a procedure, who needs an operation or needs something done, and it's not sort of designated as urgent, then that's taking a long time to happen.
Okay, thank you.
Okay, thanks. So I wanted to ask you now about the letter that you were involved in, and you and a number of other people submitted this letter to the Lancet, warning against the impact of a no-deal Brexit on work such as yours. And both the Scottish and the Westminster Parliaments have both got cross-party groups also working on issues affecting rare diseases. Can you maybe say a bit more about the letter, whether you ever got any response from government or MPs, or do you think that they understood the issues, or did you get any kind of traction with the letter?
Yeah. So we wrote the letter just before Brexit happened, of the official date of Brexit. So this was, I think, in October, and it had come about because we weren't. It'd be fair to say that 2020 wasn't the best year to be focusing on anything other than the pandemic, as far as healthcare goes, and it hasn't really received much attention or maybe it has reached the attention of the UK government, but we haven't really seen a response from them. And I was, in fact, talking to the lead author of that particular letter, and that was his opinion as well. We're putting it down to the fact that the UK government has more important things to do. But I have a feeling that there was so much, you could think, there was so much flack coming from so many angles, that this was just considered as one rather than anything else. But it was highlighting to the public, to the readership, that we do have to think of people with rare conditions. I think we focus too often on common things, and quite rightly, communicable diseases and pandemics and so on are so much higher to think about. But rare conditions will stay there forever, and I think we do need to think about these people who don't have that much of a voice, really.
Yeah. Now, I mean, in the end, there was, I mean, your letter was about the risks of no deal, and in the end, there was a deal, but the UK is still out of these
Yes.
networks.
Yes.
So for your kind of work, it's just as bad as no deal, really, isn't it?
Right. That's right. Yes. Yes. I mean, idea was that we were thinking that if there is a deal, then the deal could have included something like remaining in ERNs. The healthcare or the reference centres in the UK would remain in the ERN. And in some ways, it was actually good to get a deal, because there are other activities which people like myself and academics who are involved in, such as grants and things, which we will still have an arrangement to apply for those. But and also the work which I do at the moment, some of that work is EU funded, and that will carry on as it is. But yeah, but ERNs was one thing which didn't actually come within the deal agreement, and so that's part of the reason why UK centres have come out of that.
Yeah. And I mean, do you know what the background to that is? I mean, when I looked on the Commission website, I saw that Norway is part of some of the ERNs, and you know, I kind of wonder, were there some kind of regulatory constraints that the UK wasn't prepared to enter into that Norway is, that makes that possible, or?
So yeah, so I think it's possible that at the moment we have broken away, but it's possible that some of these things may get reinstated in some shape or form in the future. I think both sides have something to gain and something to lose, and probably both sides have something to lose from breaking off as far as the ERNs go. And we in the UK, as I was mentioning earlier on, have been working as networks for some time for rare conditions, and I was giving you the example of Scotland. So there's a lot of expertise in Scotland and in England as far as and the rest of the UK, which Europe found useful when it was developing ideas around ERNs. Even if you take data protection, or you know, the Data Protection Act in the UK has been partly informed the GDPR, and so I think from that point of view, we've been working in lots of different areas where it would be useful to keep working, and I think it's possible that in the future that might happen again. The issue about ERNs is that it's very, very closely related to healthcare, and it's not just about. It's actually mostly it's about improving quality of care rather than to do with research. So I think from that point of view, the feeling was that given the fact that this is very closely related to healthcare and it's about exchange of information about clinical practice and the governance around that, the feeling was that this would be a project which should be limited to the EU 27 states, unless there are some agreements which are with countries such as Norway. So I'm not completely sure about the agreements with Norway, but it's possible that in the future, if we were in some economic zone, or if there was some kind of arrangement, then we may be able to take part in that. Europe, some ERNs are finding solutions in some shape or form. So they have, in some ERNs, they've identified some experts based in the UK as partners, as some collaborating partners, because they would value their advice in specific cases. So those people have joined the ERN, but not as a reference center, but as with a memorandum of understanding or something like that.
Yeah, I mean, you were explaining earlier that you have an appointment in Leiden in the Netherlands, and that enables you to maintain that link.
Right. That's right. Yeah.
Does it make a difference though for patients in the UK, or are you able to, you know, how are you able to address that?
That's a very good question. I mean, there was always a concern that, and a number of us have highlighted that over the last few years, from 2016 onwards, that there would be a concern about a brain drain which would happen where people with specialist expertise would move to where the expertise was sought. So I work in Leiden because I have a particular interest and expertise in registries and creating registries for people with rare conditions. These registries are then used for research, for improving clinical care in a number of areas. And I was the person who led on the project, which was supporting a registry for patients with rare endocrine conditions. And that the coordinating center for the ERN is based in Leiden, whereas the registry coordinator was based in Glasgow myself. It would be strange to be serving the needs of a European reference network from a center which is outside any EU27 country.
Yeah.
So that was the reason why we joined forces, and I had this appointment in Leiden. But it does mean that the work which I'm doing is primarily for the benefit of the EU27. However, having said that, the registries and the platforms we have are not just open to those countries, but being based over here in the UK, we've made sure that those platforms are also open to anybody in the UK, but also anywhere else in the world.
Okay.
But if I look at the glass half full side, then I would say, well, actually, we're ensuring that whatever's happening in the EU27 countries can be applied much more widely than just those countries.
Okay. Okay. Jenny, you had something more from social media?
Yes, just a few questions really about how, had being part of these networks, do you think that accelerated the development of some treatments? And also just the idea that up till now, have patients actually travelled to Europe very often, or did they tend to do the consultations on virtual consultations and then be treated here in the UK?
Yeah, so if I take your second question first, so the patients do travel between countries, and that's happened for some very, very rare conditions. People have gone from one country to another. That within the European Reference Network, the idea was that would happen less, because what would happen is that their clinicians would know who are the experts in Europe, and they would then contact them through the CRN. So that has been happening. Patients themselves have not been able to access the platform to consult themselves virtually with somebody else. So somebody from Cyprus has not been able to consult somebody in Paris, France. So those kinds of things haven't happened, and that's not the part of the platform. If I understand, does that make sense? Does that answer the question? I hope so.
You mean they have to go via their doctors or
yes.
clinicians?
Yes.
Right.
Yeah.
Yep, that's
and
fine.
what was your first
the
question?
The other one was just, being part of these networks, does that really lead to acceleration of development of treatments and things like that?
Yes, that is the idea. I'm not sure whether that's been measured completely yet, given the fact that most of these European reference networks are about 3 years old. So I think that will take a bit longer for that, 3 to 4 years old. So that will take a little bit longer for that to be materialized. But the idea, so if, for instance, these are networks of expert centers, so they will be very well placed for running clinical trials for drugs for rare conditions. So I think all of those things. So that's part of the reason why these networks have been developed.
Okay, thank you.
Yeah. Okay. I mean, we often hear about Brexit that leaving the EU means that we can, the UK can have a more sort of global reach in things. And I know that you've also got a role as a coordinator in an international, or sort of like beyond Europe, as well. And I wondered to what extent do you think that the international sort of like outside Europe can compensate for for losing the European networks, or would ideally you wish both?
Yes, yeah, that's a good question. I mean, just a little bit about the history of that particular project you're referring to. It's called the IDSD project, and the International DSD project, and the critical part, even in that project, Europe played a very critical part in that, and that was the initial priming of that project. So that project started about 2007, somewhere about that kind of mark. So we're talking about 13, 14 years ago. And that project started initially by funding through an EU FP7 grant, which is is one of those EU-funded project grants which people get, and that was around that kind of time. And the part which Europe played in that was very much about having a group of like-minded people who had similar ideas coming together and knowing what can be done. And so that was the initial project. And so we had a group of people, and this is an informal network, but these are all European colleagues. And we had some kind of a conveyor belt. So we had the EU FP7, and then we had something else called the cost action. These are all EU funds of different types, but they allow people to consolidate and build projects. And then after that, we realized that actually people who want to use this registry platform are from other parts of the world, like Egypt or India and everywhere else. So we went for funding from the MRC in the UK, and we changed the name from an EU registry to an international registry. I had no idea that Brexit would happen, but actually that was quite a good move, because we called it the International DSD Registry at that time, and that was in 2011. So that was about 10 years ago. But the core group of people who still use that registry, although there are about 40 countries in the world who use that registry, are still the European centers who use that. But we have a much bigger group of people. So I think from that point of view, I mean, once projects mature, then they can be applied internationally. But we found Europe was very useful because it was our test bed for these kinds of projects. And it worked really nicely. And now the difficulty, if I was launching this again, I would have to think, what region in the world will be the test bed? And I think it might be, perhaps not for myself, but for somebody starting afresh, it may be slightly difficult for them to have Europe as their test bed.
Yeah. I mean, it shows the importance of kind of long-term funding, and takes a long time for things to bear fruit, doesn't it?
Yeah, and for that, Europe was quite good, specifically for rare condition research and rare disease research, because we don't have that kind of in Britain, for example, we don't have that stream of funding specifically for rare diseases. We do a lot of rare disease work, primarily in genetics, but we don't do that much rare disease work as far as care of patients go, improving quality of care and all those kinds of things. And for that, you needed that European sort of umbrella to work under.
Okay. I mean, looking forward, I don't know if Jenny's got any more questions from social media, but maybe, I mean, looking forward, what would you like to see happen in terms of the ERNs? Are you content with a kind of the workaround situation that you have with your own network, or would you like to see some kind of rebuilding of maybe when the government's got a bit more bandwidth on health issues, to look at to revisit it, once the impact of leaving becomes clearer, how would you like to see things develop?
Yes. Well, I think rare conditions, rare diseases are rare, and I'm not convinced that the way our healthcare system is in the UK, the way it's fragmented between Scotland and England and Wales and Northern Ireland, that it would be it would be ideal for all of these 4 centers to have their own rare disease networks, like ERNs. And that's my concern. So there needs to be a UK solution for it. And I think that UK solution needs to link up with the European the reference networks in some shape or form over time. But my concern is the way we're going in Britain. I mean, the way we're going in Britain is the fact that all 4 nations will go their own way, and that would be a disaster for rare conditions. And so I think that really needs careful thought. And I just haven't seen any evidence. Maybe that is happening at a certain level, but I've not seen any evidence of that happening just now. So those things need to be thought. And perhaps the pandemic has been a kind of, in a way, it's been a guiding light for how the 4 nations can work together. So perhaps they can look at other things as well in the future where they can actually work together in developing some solutions for how people can, how we can replicate and possibly not necessarily reinvent the wheel, but also look at how we can collaborate in a new way with Europe on this.
Yeah. Okay, Jenny, I think you had one more question before we close up.
Oh, yeah, I've got one question. It's perhaps a bit too specific for this evening, but also just there is some people that seem to be concerned about that they're not getting onto priority lists for vaccines. So I guess that's a more general point that we maybe can't answer exactly this evening, but just to alert that. But we've got somebody who, it took her 15 years to get a diagnosis of allodynia. I don't know if that's one of your specialisms.
No,
allodynia,
but yes.
A sort of muscular problem. She was actually a twin. She was born very preterm without muscle development, and then obviously had problems sensing heat and things. But I guess just that whole thing of how long it takes to be diagnosed, and she thinks she could have had it since birth. I don't know if you.
Yeah. So if people say that the average time it takes to reach a diagnosis for somebody with a rare condition is somewhere about 5 years, about 5 to 7 years, which is a very, very long time. And the drive of all the kinds of things we're doing is try to reduce that time. So, getting to a diagnosis much earlier is something which we are really driving towards, and those are all reference centers which we've been doing that. And then, of course, getting a diagnosis and confirming the diagnosis by some test is so important, either a genetic test or a biochemical test or something like that. So I would like to say things are much better than they used to be. But perhaps for some of the conditions, such as allodynia, maybe that's not the case. But I think we are, and recently we've been looking at our own data in the Children's Hospital in Glasgow, and where what we do is we send everybody, send people who are coming to the door, or we hand them a questionnaire and ask them to complete it. And we ask them whether they've got a rare condition or what condition they have and how long did it reach a diagnosis. And it's just recently been published. And it shows that we are getting better. We do diagnose people much more quickly than what we used to do before. But yeah, we'd like to do it more quickly.
Yeah. Okay. Thank you.
Okay. Right. Well, I think we just about need to close now. We're out of time. Is there anything finally you want to say? Anything that we should have asked you and didn't do?
No. I mean, you should. The other thing you should do is, if anybody has the time, you should look at the Office for Rare Conditions in Glasgow. They've been doing a number of different things for Rare Disease Day, which, as you mentioned, Fiona, was yesterday. So there's quite a lot going on. The Office of Rare Conditions is supported by the Glasgow Children's Hospital charity, and they've supported us in a lot of different things in European as well as local affairs.
Okay.
So yeah.
That's great. Yeah, so I think we'll put a link to also to the www.rarediseaseorg.uk on our Twitter feed and Facebook page, and also their website has some really superb videos on it, and also, like a lot of organizations during the pandemic, you know, they've been affected by a decline in donations, I'm sure. So so if you've enjoyed speaking to Professor Ahmed, as we have, then please do go along and make a donation on their website. Okay, well, thank you very much indeed for joining us tonight. It's been really interesting. Thank you.
Thank you. Thanks for asking.